excellent and extremely good, highly effective healthcare system webinar series has been going very successfully. And today, I'm very happy that, in fact, these are the people speakers who have led by examples. They have set very high standard. And one thing, what I've learned from them is they will never say no for academics. They always, throughout their life, if somebody who has kept academics on top beyond their personal thing, beyond their, all the politics which happens, it is this are the speakers which I'm talking about. This is it is Swarna Bhat ma'am. Even when I'm taking her name, I'm fumbling because that is the amount of respect and now we have towards her. One of the greatest teacher, and NNF Karnataka is very proud that we have such extremely good teachers. So now I request another extremely good academician and who is a panelist for today's session. PP Maya sir has been a former HOD, and more than anything, he has been the most important pillar of NNF Karnataka, who has stood very strong when it came to academics. So now I request Maya sir to give a brief introduction about Swarna Bhat ma'am. After that, I request today's session will be moderated by Dr. Shivshankar along with me. So I request Dr. Shivshankar to introduce Dr. Suresh and our other panelist, Dr. P.V. Ramarao from Andhra Pradesh. Over to you, Maya sir. Please introduce ma'am, and then we will start the session. Over to you, sir.
Okay, can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Hello?
Yes, sir. We can hear you.
Can you hear me?
Yes, sir. Yes, sir. Yes, sir. Go ahead, sir.
Hello?
Sir, we can hear you. Go ahead, sir.
Sir, we can hear you. We are also able to see you.
Okay, can I start now?
Yes, sir.
Yeah, I think Dr. Swarna Bhat does not require any real introduction, as already told. Only thing is my association with her for last 3 decades makes me to say something little different. Dr. Swarna Bhat and myself, we started neonatology career almost in Bangalore together in 1980s. When I was in St. John's, she was assistant to me in helping me taking care of newborn babies. That's where our association started. What I found out was she is very meticulous lady. She has problems sometimes with some people because she is too meticulous. And if we ask for about 100 marks, she is expecting 200 marks. That is her expectation. I always used to tell her during the examinations, don't expect 100 marks. You try to help the candidate, but she is so meticulous and sees that she gets out the best out of the students. Next is academics. Academics, what I know her of is she is highly academic. She doesn't do practice like us, and she is highly dedicated. And we have done many workshops and then lectures here and there throughout the Karnataka. She was the only one who was helping me throughout. We did together. I think, as Dr. Prashant Gowda said, she never said no to me for any of the programs what we planned. And she's a good teacher. And as I could see from her talks earlier, she puts a lot of effort to make the best out of it. That is in short about Dr. Swarna Bhat. Thank you, Dr. Prashant.
Shivshankar.
Shall I start?
Yeah, Shivshankar, we'll introduce and then we will start so that the flow continues. Dr. Shivshankar.
Hello, good afternoon, everyone. Good evening, everyone. Good evening, ma'am. Good evening, sir.
Good evening.
And it's my privilege to introduce other speakers. Dr. Suresh Vishwanthan, who is the director of SK's Hospital, Salem. He has done his MBBS and healthcare administration from Cleveland University. After that, he has helped his father to set up the SK's Hospital, and then has been running a 250-bedded tertiary unit at SK's Hospital, Salem. This hospital is a super specialty hospital, and I personally met him, and he's so passionate about the work he does. It runs 6 DNB and FNB programs currently, and we'll be hearing from him shortly. I'll also introduce the other panelist, Dr. P.B. Ramarao. Sir has been the head of Children's Services, Andhra Hospitals. He has been a secretary, and is secretary of NNF Andhra Pradesh. He has 28 years of experience, nearly half of that in reputed hospitals in United Kingdom. So welcome, sir, and thanks for accepting the invitation. The other panelist is my very own teacher, Dr. Asha ma'am. She needs no special introduction. She has been the director of Indira Gandhi Institute of Child Health, my professor and HOD of BMT, has been the recipient of many awards, which if I go on will take half an hour to 1 hour. You know, she has been a role model to most of us, and it's a privilege of me to introduce her, being her student. Welcome, ma'am, and thanks for accepting the invitation. So without wasting much of time, I'll hand over to Swarna ma'am to go on with the talk.
Thank you, Dr. Maya. Prashant, you can hear me?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you, Dr. Maya, for the introduction. Thank you, Dr. Prashant, for inviting me for this. I think you have done a wonderful job by having such a program, which is pretty unique. So when I start off this, I just wanted to tell you, and I'm sure a lot of you will relate to what I'm saying, that when we all started our units or our NICUs or our pediatric departments, I remember in St. John's, I used to start rounds in the ground floor with the maintenance department, with the purchase department, with the biomedical department, and then I would come to first floor where our NICU was. Because we always had problems beyond the baby as a person looking after the unit or the department or the hospital, whatever. So I think a program like this is extremely useful, not just for those who are going to be, having their own hospitals, owning their own hospitals, but for everybody who is running a department or a unit. So congratulations to the NNF Karnataka team for doing this. And with that, let me start off my presentation. The, one second, needs to move. Yeah. The mandate was to discuss these issues in terms of significance of CME and motivational classes for doctors and nurses in hospitals, how to gain and retain academic excellence in these institutions, and does academics really have add value to an institution. I've just put these as the discussion points. Academics in a non-academic institution, which please let me assure that I have put it in quotes because I don't think there is any non-academic institution. What are the benefits to the individuals, to the doctors, to the nurses, to the other healthcare personnel if we are trying to bring in academics to an institution? What are the benefits to the institution? What is the feasibility and sustainability? After all, a hospital is meant to provide to the patient and not really to the student. So what is the feasibility and sustainability of bringing in educational programs into a hospital? Should it progress to starting training programs? And I think there's enough been discussed about that, the fellowship programs, and today the DNB program. And I want to touch upon, other than academics, what else can we do in a situation like this, that is professional development and auditing. I think this particular slide will tell why it is necessary for all of us to do some teaching or training. William Osler, I'm sure, is all your favorites.
See your slides, ma'am.
Sorry?
We're not able to see your slides. Have you started sharing, ma'am?
Yeah, I thought it's being shared. You're not able to see the slides at all?
We can see. Kindly refresh, sir. Refresh your page. We can see. Go ahead.
We can see. I think there must be a problem on your side.
Oh, is it? Okay, so
Thank you. All right. So I think all of us know that graduation is not the end, it is just the beginning. And it's also obvious that when you know better, you do better. So it is important for us to continue to learn as we progress in our careers. So let me talk about this so-called non-academic institution that I talked about. The only difference is that in a non-academic institution, there is no formal training program or formal research programs. There are no students admitted to any course. It does not mean that there is no teaching learning going on. Every day, every minute, every second, in any hospital, in any institution, we are learning and we are teaching. These institutions primarily have a responsibility to their patients and to their employees, as compared to the so-called academic institutions, where formal training programs are conducted, research is being done, students are there who will be certified at the end of the course, and these institutions have a responsibility not only to their patients and employees, but also to their students. So basically what I'm trying to emphasize is that there is no non-academic institution. It's just a question of whether we are having a formal training program or not a formal training program. However, the question which is asked probably most often when we say let's have academics in our institution or in our department or in our unit, why should I take on the extra responsibility of conducting training programs? I have enough and more on my hands. I have to run an OPD, I have to run an intensive care unit. Why do I need to take on the extra responsibility? What is there in it for me? How will it benefit me? How will it benefit my institution? Will it bring more patients? And the usual thing, we conduct so many training programs and the nurses and the doctors leave. So for this, I have a very simple answer for the last question. The only thing worse than training employees and losing them is to not train them and keep them. So I think that answers the question why we need to continue to train even though our nurses and our doctors keep leaving. What is a benefit to us? I think it's summed up in these 3 slides. Teaching is a great way to keep learning. And I think that is the most important thing, that we keep teaching, we keep learning. But let me go into the specifics. Does it benefit individuals? Does it benefit patients? Yes, it does. Continuing education helps in improving patient outcomes. Healthcare personnel are able to provide better care. Healthcare personnel can refine skills and therefore improve overall patient care. Does it benefit the healthcare personnel? Yes, it does. They gain knowledge and stay up to date with the latest developments. It helps in their professional growth and can be a means to advancing their career status, helps in personal growth, learn effective team management skills, learn leadership skills, and so on and so on. So therefore, it definitely does benefit the individual. Now, how does it give value to an institution? Nurses and doctors are more knowledgeable and skilled, therefore their performance will be better. They would be practicing state-of-art, up-to-date practice. Patient outcomes are better. Improvement in soft skills, especially when we conduct communication programs and counseling sessions. So there's less problems with patients and their families. And this to me is a very important statement. Students are our conscience keepers. You tend to practice more correctly when you have somebody junior with you who will look up to you and say, oh, this person is going to do the right thing. I have always said that in our OPDs, undergraduate students used to come. And a lot of faculty would be upset saying that I can't see my patients well if these students are there. And this is the answer that I would give them, saying that if you have students, you will not do anything wrong. On-rounds discussion empowers both faculty and students, and institution becomes known as a care provider and, of course, a training center. So after having said that there are benefits of conducting training programs in an institution, let's see what is this continuing education is, because obviously whoever has come have finished their formal training. So education that is provided for adults after they have left the formal education system is what we call continuing education. And obviously it can be in terms of knowledge, skills, communication skills, and professional development. Having said that, is there any evidence that it improves patient outcome? And I have a few slides to answer that. And how should we be evaluating these training programs? And I have some messages regarding that. I'm sure a lot of you would have looked at articles and found that, yes, it makes a difference. So this is an article which talks about a team training, improved effective learning, cognitive learning, skill-based learning, teamwork, etc. It improved patient satisfaction, reduced mortality, and reduced medication errors. So not only are we talking about the improvement in the healthcare personnel, but also in patient outcomes. This is something I'm sure all of us have been doing, but it's got a terminology now of in situ simulations, which are basically simulations which we do not do in the simulation labs or centers, but we do it in the real working environment, that is in the NICUs and in the pediatric wards, etc. So again, there is evidence that when these kind of simulations were done in pediatric units or adult units, the survival after cardiopulmonary arrest improved from 32 to 56% and so on and so forth. And when these kind of in situ simulation was done in pediatric emergencies by an emergency team, the hospital deaths came down and the MRSA infections came up. So not only does it improve the knowledge, it also improves the outcome of patients, which is what we need to be looking at. The last time Arvind mentioned about mentoring, and I think this is something extremely important, even if you can't have a formal set of training programs going on in your institution, some kind of mentoring of your junior faculty or of the nurses is extremely important. And there is enough data to say that at whatever level, be it at a primary care level, as is in this particular article, or in a tertiary care level, certainly the knowledge and the outcome improves. So this is done in PHCs, and you find that the nurses found it that they were able to provide better care. They were able to handle maternal and newborn complications better. They were able to handle the equipment and supplies management and the referral management. So at whatever level, some kind of training definitely helps. The next question I had was that how should we be evaluating these training programs? Conventionally, we do a pre-test and a post-test. And if we are a little more adventurous, we say, okay, we need to check on the retention, and therefore we do a retest after 6 months, which would have dropped. And then we do a re-post test, which would have increased. But the point I'm making is it's just not enough to find out if there has been transfer of knowledge or skill, but we also need to address, has it improved the patient outcome? Having said that, let me divert a little bit to talk about the experience that I have had in the last 30 years. Yes, in St. John's, when we looked at doctors training, we had postgraduates, we had undergraduates, we had short-term training programs of various levels of doctors from government and private sectors. We then developed fellowship programs after a long time. I think 2008 is when we started. Then we had the neonatology DNB, and then of course the DM neonatology. So it's not necessary that every institution should move up to having formal training program, but whether there are students or not, I think we need to conduct programs. The experiences with the nurses were extremely hard, very nice. I remember in the early 1990s when we started the NICU. At that time, the nurse would not even come for rounds. And I remember once a week sitting with these nurses. Dr. Lalita from Manipal had brought out a nursing manual, the NNF nursing manual. And I used to make them read one chapter by one chapter so that over a period of time, they all knew what were the protocols. So then we started this training of newly joined nurses, that when they came, of course, it's difficult, sometimes very difficult because they keep coming and keep going. But somehow we manage that every time a new set of nurses come, we do a kind of training for them, both in skills and in knowledge, because unless they know why they need to treat hypoglycemia, they're not going to react to a GRBS of 25. Then, of course, the specific, more formal training programs for our nurses, the neonatal resuscitation, kangaroo mother care, breastfeeding, etc., etc. And then much later, in the mid-2000s, we started having these online training programs, which again was mentioned by Dr. Arvind. It involved certification and therefore it was useful. And then we had a lot of hospitals starting off NNF nursing fellowship programs. But we didn't start that, but we started involving our nurses in research. We started asking them to present papers at conferences, and we started taking them as resource persons and faculty. So we really empowered the nurses. I'm not saying it helps in retention, but it certainly makes them feel good and makes us feel good that we are taking our nurses along. Innovations which helped: drills, the same in situ simulation that I was talking about in NICU. I still remember this was even before the fellowship training program started. I would suddenly get a mannequin to one of the empty beds and say that this baby is convulsing, and would get the nurses and doctors to do things and then debrief them saying, look, this is what went right and this is what went wrong. So now it's got a beautiful term of simulation, but I'm sure all of us have done this, and this really helped sort of fine-tune skills, particularly team management skills in an emergency. Then, of course, the training of new postgraduates at the beginning of the courses, we spent almost 1 or 2 months training them, whether it was for a postgraduate, whether it was for a DM neonatology or a DNB neonatology or a fellow. Then training programs for nurses, which I have already alluded to. Training of all healthcare personnel, even the class 4s, even the AYAs, even the helpers in infection control practices, even the radiology technician, everybody would be trained in infection control practices. Evaluation by OSCE. So PGs at the end of their posting, at the end of their NICU posting, we used to have an OSCE evaluation. And I still remember the kind of OSCE stations that I used to put was connecting the ventilator, the tubings, not connecting the ventilator to the baby, but connecting the tubings. And then we started having OSCE evaluation for interns at the end of their internship. And of course, for the undergraduates, because they were coming in for such a short period to the neonatal unit, we started having a structured training for them, and I think that also helped us and helped them. NH, again, the experience was very different, but very useful. The training there was sketchy and on paper when I started working there. So regularized their bedsides and seminars for postgraduates. That was not very difficult. Improved bedside teaching, which was a little more challenging, but was able to do meaningful rounds. Conducted training programs for nurses. They already had, because of the NABH accreditation and things, that they were all trained in infection control, but it did never amounted to implementing. So conducted training programs for nurses on infection control, KMC, breastfeeding, and what was most satisfactory was that this actually resulted in change. All these practices were implemented thanks to those wonderful nurses, which I was able to motivate. Lessons from various training programs. I think many times this is done for the sake of doing, and I think we shouldn't be doing that. Knowledge transfer may be there, but we don't know about retention. We don't know about changing behavior. We don't know how much motivated these learners are. And I strongly feel that small group sessions and workshops definitely are better in acquiring skills and motivating a person. It gives in-depth knowledge and imparts skills. It's not that everything can be converted to a workshop, and it's still okay to conduct CME programs and CNE programs, because at least a small percentage will follow and will take it up to its logical conclusion. Again, I'm talking about how do we evaluate. And I think we need to look for retention of knowledge and skills, which I have already alluded to in the previous slide. Sorry. Yeah. So importance of retention of skills and knowledge. Why is it so? What happens? There is no point doing a one-time training program and expecting people to do perfectly, whatever it is, whether it is KMC, whether it is breastfeeding, whether it is ventilation, surfactant, whatever. There is a problem both in low volume centers and in high volume centers. In low volume centers, you have trained all your labor room staff in resuscitation, but they may be doing, for example, in a primary health center or a low volume hospital, they may be doing bag and mask ventilation once a month or once a week, and that's not adequate. So we have to do ongoing programs. Similarly, in high volume centers, there's likely to be high attrition of nurses. Could also be high attrition of doctors, because if you have your interns and postgraduates coming in and going out. And therefore, I think we need to continue to train. And we need to have, just like your PDSA cycle for quality improvement, we need to have a training, audit, assessment, feedback, retraining cycle, so that this training eventually becomes a norm and the knowledge or the protocols become a norm. And the classical example of this ongoing training or an in situ simulation is the paper by Dr. Manisha on every labor room staff would enter the labor room after having practiced bag and mask ventilation on a mannequin at the entrance of the labor room. And this is some concept I had tried to introduce in all district hospitals when I was there in the as a child health advisor. I don't know what happened subsequently to that, but this is one of the programs which I had said that we need to do to improve resuscitation skills. Now, having talked about the importance of training programs, that it is beneficial, how can we go about doing things, and whether we need to do a formal training program or not. My only message, there's been enough talked about that yesterday, the last session, and today Dr. Suresh is going to be talking about DNB programs. My only message is that if you accept to take a student, there has to be a commitment and a responsibility to the student and the program. It is unfair that we accept students and don't train them. So that's all I say, that if we want to have formal training programs, we need to take on that responsibility also. Okay, this is almost to the later part of my talk. I said I also want to touch upon two things of professional development and auditing. So far, what I've talked about is knowledge, skills, etc., pertaining to our own specialty. So what is professional development? Very simplistically put, it is what you learn after your formal education and which helps you in your career. And I'm sure Dr. Maya or Dr. Asha will agree with me that we have all learned it on the job. And I'm sure all of you are also learning on the job. But over the 30 years, I find that this passion for learning need not be uniform in everybody. And therefore, we need to conduct these programs to make sure that everybody are on par with each other. So what are the issues covered in professional development? There are umpteen things. And in fact, this particular course of how to build a hospital or a unit, I would take it as a professional developmental course. It could be on medical legal issues, health records, electronic health records, counseling and communication skills, managerial skills, leadership skills, quality initiatives, anything beyond what is conventionally taught in neonatology, in pediatrics, in medicine, or whatever. So how do we go about doing these training program in the so-called non-academic institutions, or better way to put it as where there are no formal students? So I think we need to look at general topics for all faculty and nurses. Let's say I'm running a hospital. I would like all my faculty and all my nurses and all my healthcare personnel to know about infection control practices and to know about cardiopulmonary resuscitation. I want my nurses and my students and my faculty to know specific to their subjects, NRP, PALS, IMNCI, whatever. And then I want my faculty and my senior residents or the junior faculty to update themselves and upgrade themselves by attending or by conducting CMEs and specialties. And I would like them to improve their skills, example, again, counseling and communication skills or whatever. It could be surfactant administration, it could be managing a 500-gram baby, it could be anything. But this is the way to start off. General, what do you want everybody to know? And as you go along the hierarchy, I think it's important even for the senior most person to keep learning and upgrading their skills. My motto has always been think big, start small. I know a lot of people will say think big, think big, think big, think big, and start big. But I find that starting small helps because you need to move up gradually. So you could start off with in-unit training, inside the department training, within the institution by in-house faculty, within institution by guest speakers and experts. This is something I have always noticed, and a lot of you will agree, that when we talk to our own colleagues, the value is not as much as when an outsider comes and talks. So I'm just saying, how do we move up our training programs? So you need to invite guest speakers, you need to have, and then you need to organize training programs, conduct workshops, etc. But whatever it is, in your annual calendar, when you're presenting your annual report, your financial report, your whatever, also say, this is my agenda for the training, teaching, learning program for the next couple of months, years, 6 months, whatever. So have a schedule and adhere to the schedule. It sounds very good that we can do this, we can have a beautiful calendar, we can get it inaugurated, blah, 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 etc. But how is it possible to sustain these training programs where the focus is on patient care? It is a challenge. So we need continued support and motivation by the management. We need to have a dedicated person for academics. There is a slight downside to it, that when you have somebody who is dedicated only to academics, the tendency by all other personnel, whether faculty or nurses, oh, he's doing it, she's doing it. No, the important thing is that this dedicated person, the role is to coordinate and conduct training after having involved everybody. It cannot be a one-person show. And it's important to get feedback. It is important to do a survey and say, okay, what do you want? Do you want infection control? Do you want something else, etc.? And auditing, not just of the training programs, but auditing of patient outcomes certainly helps us to know what direction we need to go in terms of training. So coming to auditing, the first statement I want to say is it should not be just for accreditation. It's a process used to assess, evaluate, and improve care. It measures our current practice against a defined, desired standard, and it helps in improving quality of clinical care of patients. So, whether you're starting training programs or not, whether you're going to be doing official training programs, this continued ongoing learning will happen with informal training programs. And I think auditing is something very, very important. And again, I'm not going into the details of this study. We all know that once we have done some kind of an intervention, the hand hygiene practices improve. But I think what is more important is that there was a decrease in healthcare associated infection. So therefore, whatever our training programs, our auditing, our practices should, the ultimate is that we need to improve patient outcome. So just like the PDSA cycle, we have this audit cycle, set standards, measure current practice, compare, reflect, change, re-audit, etc. There are two other concepts or three other concepts I would like to take this opportunity, Prashant. This is not part of the mandate that I have been given about the usefulness of motivational talks and conducting CME programs or CNE programs. But I thought these are a little futuristic concepts which we need to start looking at. A lot of you who are listening are leaders or will be future leaders. The current concept of patient care is disease-centered. I'm just taking an example of a high-risk neonate. You could take an example of a diabetic or whatever. So a high-risk neonate has to visit multiple people, a neonatologist, a developmental pediatrician, a neurologist, ophthalmologist, etc., etc. But when we talk about a patient-centered practice, we run a high-risk follow-up clinic where all these specialists are available at the same time. And what is important is that this is different from primary care. It is not basic care that is being given, but it's advanced care that is being given. I'm not saying that everything you can have. I'm not saying you should have a fever. Of course, fever clinic is the most important thing in the COVID times, but there are certain things that we can convert it into integrated practice units where you're looking at the patient as a whole and not just bits and pieces of the patient. The second concept, which I thought is important to introduce, is changing goals. Our current concept, suppose I'm running a hospital or I'm running a department and I'm answerable to the management. I'm looking at patient numbers, I'm looking at the procedure numbers, and I'm looking at the money, financial profit. But I think it is important that we must shift the focus from volume and profitability of services provided to the patient outcomes achieved. I thought that this is something very important, and I didn't realize that this is what I'm doing. But whenever we had an annual presentation, every January we used to have the annual presentation of NICU, PICU, pediatric, etc. And we used to make a presentation to the management. And in the management presentation, in addition to the numbers, we also talked about the mortality, the morbidity, how outcomes are improving, etc. So the goal for providers as well as for all stakeholders should be improving value for patients. And there is a newer definition of value for patient, which is defined as health outcomes achieved that matter to patients with minimal cost. So best outcome at minimal cost without compromising on quality of care is what I'm sure everybody wants to do. And I think we need to aim at it and see. I know it sounds very unbusiness-like, but I felt that I would like to share these concepts. And the last concept, which I think is something I found it very, very, very important, that when we talk about patient outcome, we say, what is the BSID score or the DASI score of my VLBW babies? Do we look at how many of my VLBW baby can go to a regular school? Do we look at how many of our low birth weight babies or our asphyxia babies have been able to go to 10th standard? Second, when we are looking at follow-up, we are looking at, okay, we had no BPD, we had 3 ROP, we had no hearing loss, etc. But what matters to the patient is how many visits do I need to keep coming to this hospital? What is the financial burden of these, etc. And third, again, when we are looking at sustainability of health, from our perspective, we are looking at growth and development, and we are very happy. The baby's growth is fantastic and the development is fantastic. But we're not looking at their participation in physical activities, we're not looking at their scholastic performances, etc. So all I'm saying, I think we need to start looking at outcomes that matter to the patients, in addition to outcomes which matter to us. And the reason why I brought these concepts was basically, as I mentioned earlier, everybody listening here is a leader. That's the reason you have organized such a fantastic program. Okay? And it's for us to think beyond what we're doing right now. So I'll end my presentation and thank everybody for listening and for the opportunity with one last slide, which I really like. When writing the story of your life, don't let anyone else hold the pen. And I'm just wishing you that each one of you will be able to write your own life stories without too many hindrances and the way you want it and the way you like it. Wish you all the best and stay safe. And thank you once again, Prashant and the NNF Karnataka team. My presentation is over.
You can just stop presentation.
All right, how do I do that?
Icon you have to click again
Yes.
after the mic icon. That video icon, mic access.
Done?
Yeah, you have to click on the. Yeah, Dr. Suresh can start presentation. This will automatically stop. Dr. Suresh.
Hopefully.
Yeah, Shiv Shankar, over to you.
Yeah, stop presenting. Done.
Shiv Shankar, kindly unmute yourself.
Thank you, ma'am, for the excellent presentation. It was always a joy to listen to you, and it's still, being joy to listen to you always. Thank you for sharing your experience and giving the immense knowledge to us. Thank you so much. We'll be taking the questions at the end of the session. Now, I've already introduced Dr. Suresh Vishwanthan, who is the director of SKS Hospital, Salem. Welcome, Dr. Suresh, and thanks for accepting the invitation. Can you hear me? Yeah.
Yes,
it's over to you. It's over to you. Yeah.
Can everyone see my presentation?
Yes, we can see. Please go ahead.
Thank you. Actually, it's an excellent talk that Dr. Swarna Bhat said that perfectly leads into my topic. Thank you, ma'am. I'm honored to have listened to you. And I apologize for holding you on everyone on a Sunday because this is going to be a slightly long topic just because it's a vast subject, and I've tried to concise and bring it as small as possible. So I hope everyone knows what the National Board of Education is. It was set up by the Government of India. It is recognized as an alternative postgraduate teaching system. Unfortunately, a lot of doctors themselves are a little in doubt about it. And NBA conducts a lot of programs on par with all the MCI programs. They have broad specialty MS, MD programs equivalent. They have special fellowship postgraduate courses. Super specialty, which was recently, just about a week ago, in their announcement, renamed as DRNB. Earlier, you could be the equivalent of, say, a neurologist, having done DNB medicine, DNB neurology, and both would be DNB. Now the super specialty has become DRNB, neonatology, DRNB, nephrology, etc. A few postdoctoral fellow courses, and something that's newly been announced by the national board. They've started 2-year diploma courses. With the MCI deciding to wind down diploma courses in medical colleges, the national board has been asked by the government to start 2-year diploma courses. The qualifications are recognized by the government of India and can be registered with your state medical council. I'm not going to go read everything in the slide. Unfortunately, the slides have to be a bit text heavy, but what you see are the broad specialty programs. Year on year, they do add or remove some programs, and this is the latest 29 broad specialty DNB programs. They have 26 super specialty DRNB programs. I should get used to calling them DRNB. FNB, these are post MD or DNB, MDMS/DNB courses, which are 2 years, and they have 16 of them. Postdoctoral, after your DM, MCH, or DRNB, 3 of them. These are the new 8 diploma courses that have been started, and they award the same diploma as the universities used to, with NB in the bracket, 8 of them. So let me jump straight in to accreditation with DNB. So to start off, what is the cost? The cost is approximately 2,40,000 in terms of accreditation application fee. Till last year, there was no GST, and the government suddenly woke up and decided that even university accreditations should have GST, which I feel is not justified. But suddenly, from 2 lakhs, it's jumped up by another 40,000. There are 2 windows for accreditation in January and February, around January for broad specialties and around July for super specialties. Currently, it's actually open till the end of this month. Although they say July, August, National Board does delay releasing the actual application, and it was just released last week. And anyone who wants to start a super specialty or fellowship program, it's still open currently. They give you about 4 weeks to complete the online application. The whole thing is online now, and about 4 more weeks to submit all the paperwork as hard copies. This is a flowchart taken from them. So once you submit the online application, it gets scrutinized. National Board has become much better dealing with nowadays, and if there are any issues that they have queries, it's sent back to the hospital to give clarification, and then there's an assessment by an assessor who comes, verifies all the paperwork, visits the department, the hospital, etc. It is submitted to the National Board and finally approved by the governing board. So the final outcome takes about a year from the time you apply. So if you want to start programs in 2021, you should have applied 1 year in advance. So they have certain minimum criteria. The hospital should have the required bed strength. I will be detailing more on the bed strength in the next page. IPOP patient load. It should have been 1 year of operations at the time of applications. So that's 2 years by the time you actually start a program. And on mandatory licensing like a Clinical Establishment Act, fire safety, etc. should be there. Earlier, National Board had a requirement that hospital could only be 200 beds before you could start a National Board program. About 2 years ago, they've relaxed it a bit. So if you have a hospital that's about 200 beds, there's no restriction on the number of courses you can start, provided you have the required infrastructure in each department. Now, hospitals less than 200 beds, 150 to 200 beds, can start 3 programs. Less than 150 beds, 100 to 150, so they can start 1 program. Multi-specialty hospitals and single special, predominantly in one specialty, for example, an orthopedic hospital that has other specialties, or single specialty hospitals that have, like for example, a maternal and child health hospital, they can start several programs in that specialty, provided they have at least 100 beds in this in that allied special, the single specialty or the predominant specialty that they're looking at. This is a significant relaxation because I do know of an instance a few years ago where a maternal hospital, NB actually came for inspection and said, you've got pediatric services, so you can't be considered a single specialty hospital. This actually did happen, and this clarifies that. Some specialties which are predominantly outpatient based, like endocrinology, dermatology, as you can see in the last, the workload is mostly outpatient based, and they look at the OP caseload. So quickly, these are the single specialty hospitals. Coming back to my example, a hospital that is predominantly maternal and child health services can start DNB in obstetrics, pediatrics, neonatology, and have fellowship programs in reparative medicine and maternal fetal medicine, etc. Similarly, for other specialties that you see over there. So for broad specialties, the basic, if you look at OBGYN, medicine, surgery, you need 35 beds. For pediatrics, 30 beds. The others that you see there, like orthopedics, radiotherapy, etc., it's 25 beds. Emergency medicine, you need 10 beds in your emergency room and 15 beds in your ICU. For all other departments, it depends on the caseload. And they specify something as general beds. It says 35% of those beds should be general beds. Now, clarification is, for a long time, a lot of people, including me, used to think that the general beds meant general ward patients. And NB also used to add to the confusion, saying that these are beds that are being run at cost. Earlier, it used to be free, then they said at cost. Now they've clarified, saying that 35% of the beds should be earmarked, saying that your postgraduate trainees are allowed to treat patients in that bed. That's all. It's very simple. So if you've got 50 beds and you say, I'm dedicating 20 beds where postgraduate students are allowed to be participating in the treatment of those patients, then that's fine. It could be 100% wherein you say postgraduates are involved in all the beds. Coming to super specialty, specialties like neonatology, critical care are 10 beds. I'm not going to read through the whole thing, but just to give you an idea, the application that National Board has available on their website gives more detail on all these. Fellowship programs are considered subspecialty. So, for example, spine surgery is a subspecialty of orthopedics, and the requirement is based on orthopedics. If I recollect correctly, orthopedics was 25 beds. So as long as you have 25 beds and you have faculty for spine medicine or spine surgery or sports medicine, you can start a FNB program. Coming to the faculty. This is an area that National Board has significantly relaxed over the years. Earlier, the faculty requirement used to be one senior consultant, 2 juniors, and 2 residents. Now, all that they ask is that we have 2 faculty, one of whom should be a senior consultant. The other one can be either a senior or junior consultant. I will, on the next slide, will explain what they mean by a senior or junior consultant. The qualification should be recognized by the Indian Medical Council Act. More on that. And earlier, there used to be a requirement for a postgraduate teacher that someone who was previously having experience teaching postgraduates could only be qualified as a postgraduate teacher. A few years ago, this has been a significant relaxation, which allows almost every hospital to start a postgraduate program, because now anyone who's a senior consultant is considered a postgraduate teacher, as long as they give an undertaking saying that they're willing to teach postgraduate students. Coming to the last point, research. This is something very important. They have mandated that the faculty, between the 2 of the faculty that we're showing, they should have at least 5 research activities to their credit. And this research could be publications, it could be case reports, and even presentations and poster presents in conferences. This is also quite significantly relaxed, because earlier they used to specify it had to be an index journal publication, but even presentations in conferences are now being accepted. So for broad specialties, it's simple. Consultant is someone who's got 8 years of institutional experience. A junior consultant is 5 years. Now, when it comes to super specialties, if you've got a DM or MCH or DNB, then 5 years makes you a senior consultant and 2 years makes you a junior consultant. But in some specialties where they use, for example, if there are no super specialties, but you've got someone who's qualified as a broad specialty and has got experience, exclusive experience in that area, then they may consider if you have provided 8 years experience. For example, critical care medicine. If you've got someone who's qualified as DM critical care or DNB, 5 years and 2 years is enough. But if someone who's MD anesthesia or general medicine, and you want to show them as faculty for critical care, they should have 8 years and 5 years respectively to be accepted as faculty. Some courses like family medicine and emergency medicine have unique criteria. It varies. Now, this is one of those ambiguities that they have. Earlier, they used to say that you need to have 2 senior residents who are basically fresh graduates within less than 5 years of experience. But now they use the word senior residents are desirable. So it's not mandatory, but I don't know why they say, included saying desirable. If they're going to give you accreditation even without it, then why show it up? But that's what the application, the criteria says. 2 senior residents are desirable in the department, but you can apply with just 2 faculty. Now, this is something that they're very particular about. You cannot use part-time faculty. The faculty have to be full-time. The hospital that they're working, your hospital or institution should be their primary place of practice. They are allowed to have an outpatient practice, which is in a non-academic setup. That's the words that they use. But they can't be visiting faculty or visiting consultants in other hospitals. Earlier, they used to verify using Form 16 to show proof that you're actually paying them a monthly salary and that they're part of your institution. But now of late, they've started insisting on Form 26. For those who are not aware of this, these are forms generated by the Income Tax Department. Form 16 shows your TDS, the TDS that you pay to that particular doctor. And Form 26 is generated by the consultant's auditor. And it shows all their sources of income. So if they've been working in 2 hospitals, that comes up on Form 26. And they have in the past asked for salary statements from the hospital and from the doctor also. So they do go in depth in verifying that the faculty that you're showing are full-time with the hospital. You can use part-time faculty as guest faculty, but like I said, they're not considered as part of the teaching faculty, for accreditation purposes. So an undertaking from the faculty is that they will devote at least 10 hours for teaching every week, in addition to the regular clinical, excuse me, I'm sorry, in addition to the existing duties. And the minimum teaching should be of 5 hours of seminars, journal clubs, etc., and 5 hours of clinical bedside teaching. And the consultants will also have to attend CME programs conducted by the NBE to keep them up to date. So they ask for the required patient load in the department. I think I have a slide on that later. They ask for data for the last 2 years. Supposing your hospital has been only functioning for 1 year at the time of application, when the assessor comes, they will ask for the data for the last year from the time you've applied till current to verify that you have the required caseload. In surgical disciplines, they ask for the theater register, theater caseload, and also a case mix. So if you're applying for general surgery, they also want a breakup to see what are the type of surgeries that you do. In pediatrics, what are the type of patients that you get. So case mix is also important. And we do verify it using your hospital information system, OT registers, etc. So coming to the teaching and training facilities, NBE also requires that students have training in basic sciences like anatomy, physiology. Again, this is one of the things where they've significantly relaxed the requirement. Earlier, you had to have MS anatomy, MD physiology, and consultants coming in and faculty teaching. And it was always difficult because most of them work in a medical college and you had to get an NOC from the medical college for them to come and teach here. And NBU is asking for the NOC. Now you can have an in-house team of physicians, orthopedic surgeons, and your lab microbiologist and biochemist teach the students. So this makes things much more easier. If you can't, the other alternative is you can have a specialist from other hospitals visit basic sciences, or you can tie up with an institution if they're willing to give a tie-up and show that our students are going to get trained at their institution for basic sciences. An institutional ethics committee is mandatory, so it takes time to formulate one and get it registered. So you need to have accredited institutional ethics committee, which once you, it's not just forming the committee, like I said, but it has to be registered with the government and approved. If you do not have an in-house ethics committee, you can tie up with a neighboring institution which has an ethics committee, and that's also accepted. And you can tie up, like I said, for an institutional ethics committee, but you also need a scientific research committee, which is part of the hospital, and it's fairly straightforward. You can have one. You just need to formulate it and then submit it as part of your application. So the IEC and SRC vet and evaluate the thesis proposal of the DNB trainees. And word about thesis, National Board puts a lot of importance on the thesis. So right at the time of admission, the students have to decide with their guide on what the thesis is going to be, submit it for National Board approval, then get it cleared by the SRC, and then finally by the IEC. Coming to library facilities, each course, National Board does give a list of recommended journals. You have to have 4 journals, of which 2 should be international journals. So they recommend 2 Indian and 2 international journals. And they do accept electronic journals, so online versions are fine. And again, subscription of these journals have to be in the name of the hospital, not in the name of the consultant, not in the name of the head of the institution, and in the name of the hospital. And this can be quite expensive. Typically, if you do go to the international websites for subscription for any of the journals, for example, British Journal of Anesthesia or Oxford Journal of Medicine, they have an individual subscription and an institutional subscription. And while an individual subscription may be $500, etc., an institutional subscription can be as expensive as 10 times as $5,000. So, but they ask for receipts showing that it's the name of the institution. They give a list of textbooks and reference books that have to be purchased. Again, they ask for proof in terms of the bills from your bookseller showing that these were bought in the name of the hospital. And all this is verified by the assessor when they come. Trainees, this is fixed by the National Board, and this is how much you can charge from them. So in the first year, for each year, the academic fee is 75,000, library fee is 15,000, and annual appraisal fee is 15,000, and your accommodation, if you're providing accommodation, is 20,000. So it comes to 1,25,000 annually per student. They're very particular that you do not charge anything more than that. No capitation, no bond. Anything in excess of this, any charging in excess of this, can result in you being basically kicked out by the National Board. Stipend. This is another point that National Board keeps bugging us and asking us to give yearly undertaking saying that we are paying the stipend. So the stipend is fixed by the National Board, as you see over here. It ranges from about 35 to 43,000 depending on the specialty and the year. But there's a caveat saying that either this or whatever is paid by the state government for government students in the government hospitals, government medical colleges, whichever is higher. So, for example, I'm in Tamil Nadu, and the Tamil Nadu government stipend for postgraduate students is higher than this, and I have to match what they are paying. Students have something called a grievance redressal committee because there have been complaints from students that they're not getting adequate training, or that whatever issues that they were having were being sent directly to the National Board. Now this is like an intermediary step where they can represent to the board, sorry, to the committee, and the committee has a chance to rectify it. And even if it's escalated to the National Board, it comes back to the committee and they have a chance to fix it. So there are various advantages to running a National Board program. One is you have a dedicated set of residents. As anyone who's running, a hospital or works in a hospital knows, junior doctors often, they finish their MBBS, they're more interested in getting into a postgraduate program than really learning. So working as a duty doctor or duty medical officer is just a stepping stone, and half the time they, with their books. Whereas when you've got a postgraduate resident, he's got 3 years, 2 to 3 years of dedicated time wherein he's there to learn. You also get to teach him, train him the way you want, and by the time they come to the second year, third year, they're definitely much more qualified than a duty medical officer. And they're not going to take time off for appearing for entrance exams, etc., because very strict leave policies. So that's predominantly one of the biggest advantages. And in today's COVID scenario, frankly, our postgraduate students who are helping us manage the huge caseload of COVID patients. Teaching keeps you current, like shamelessly stealing from the previous talk. When you teach, you learn twice. There was a very nice slide by ma'am. And yes, teaching definitely keeps you current, keeps you up to date, and the students keep you on your toes. There's definitely a prestige as a postgraduate teaching academic center. Get peer recognition, chance for international collaborations when you go abroad, even as for like conferences or faculty. When you're a teacher, there's a definite level of respect given to you. And for institutions, it's a marketing opportunity saying, we are a postgraduate training institute. If you notice, we also mentioned that in our hospital, we say we are a postgraduate medical institute. So people recognize you as being a step beyond other hospitals. There is a definite cost to running an MBA course. Like I said, the application fee, which I mentioned earlier, about 2,40,000. That's once in 5 years. Yes, it used to be once in 3 years, and now they made it 5 years. So that's a little help. Subscriptions, like I said, have to be in the institution's name, so that can be quite expensive. If you're subscribing to online resources like Elsevier's Clinical Key, Walters, Culver's Up to Date, again, an institutional subscription runs into double digits in lakhs. You need a dedicated administrative and library staff to take care of the program. You need space for library, skill lab, classrooms for them, administrative office, and even accommodation. And even if you're renting accommodation outside, you're going to be paying much more than what the students are paying you as the accommodation fee. Like I said, 20,000 per year definitely does not cover the cost of accommodation. And if you're using external faculty for basic sciences, you have to pay them also. Responsibilities, as you definitely have responsibilities as an NB institute. First of all, you have to do right by a student. Like the previous speakers, ma'am said, if you're accepting someone as a student, you definitely have you have to do right by them. You have to ensure that adequate training is given to them. Do not treat them as slaves that you can extract work from. Respect them as fellow doctors. Yes, you can get a lot of work out of them, but they still need to be respected as fellow doctors. There's also there's a lot of competition now for NBE students because it's central allotment, and it's your students who tomorrow are going to be your best marketing. Because of social media, and students now are smart. Before selecting institute, they get in touch with previous students or current students, and they ask, how is the training, how is the facilities, etc. So they are going to be your number one promoters if you do right by them. NB requires that you have the students maintain a logbook that's up to date. It's their proof of training. There's an annual formative assessment test by NB. Sometimes they ask you to conduct it also. The thesis, it should be of publication quality. The research thesis should be of original research, and ideally get your students to publish it in an index journal along with their thesis. And do involve your postgraduates in conferences, poster presentations. It's part of the training program and will improve the quality of the program. Now, some issues of running an NBU program, like I said, definitely additional cost, and sometimes can be difficult to justify it to the board or the finance committee. It opens up your books for inspection because the assessor is going to look at your financials, your consultant's financials, and you have to be open. A lot of hospitals have double accounts, and it's going to be difficult for them because then they can't show their actual accounts. So you have to be above board. There is a lot of paperwork involved in running this program. NBE can be very bureaucratic. It used to be much worse earlier, and definitely they've improved a lot, but there's still a lot of way to go to. There's no way you can just pick up a phone and ask someone at the national board. All communication has to be by email, and sometimes the email questions can be difficult to understand. I've had issues where they repeatedly ask for the same thing, although we've submitted it, and it's difficult to see what it is that they're exactly asking for, because our interpretation and their expectation might be different sometimes. If there's any change in faculty, if someone leaves as a faculty, you need to replace them immediately unless you've got extra faculty. And one of the disadvantages is, although the faculty are teachers and they're teaching on par with your medical college, they're not granted recognition as a professor, and that irks a lot of people because we are running quality programs and they don't get the peer recognition. Now, the Medical Council and NBE have been at loggerheads for quite some time. NBE degrees are not, well, they're not degrees, but NBE qualifications are not immediately accepted by MCI for teaching. And this, in spite of being repeated government orders and court rulings, they still insist that NBE postgraduates have to do a year of senior residency before they can be accepted as an assistant professor. NBE faculty are not invited as external examiners to MCI programs, postgraduate exams, and often even when you see government job advertisements and vacancy listings, they don't mention DNB as an acceptable qualification. There are some alternatives to NBE. A lot of state health universities have fellowship and postdoctoral programs. I know Rajiv Gandhi in Bangalore, Karnataka, and NJR Medical University in Tamil Nadu has several fellowship programs run, which you can get accredited to, and it's much easier compared to NBE. A lot of the national associations like NNF, IAP, and CME conduct fellowship programs, and these programs are actually quite valued in the Gulf, I believe. And there are some international programs, just to give some examples, like Texas American University, and which conducts postgraduate programs, although I think there have been some issues with the MCI currently, but they've been there in the past. And then institutes like Jefferson, who conduct an ultrasound training program. So what are the improvements? Having said all this, a lot of people still don't understand that DNB qualifications on par with university qualifications, and most people think it's just a diploma, and it's undervalued. Ideally, the government has come up with the next for MBBS and exit exam. Why do we have two different streams of postgraduate qualification? NB could become a common exit license exam, irrespective of whether you study in an NB institution or a medical college institution. And although the government recognizes qualifications from English-speaking countries, postgraduate qualifications, FRCS, MRCP, etc., NB, even in the criteria, they say MCI recognized MD, MS, DNB, or equivalent, and they say equivalent is recognized by MCI. I personally have had issues, and I know others have had issues when you try to give faculty who are MRCP qualified and have the adequate experience. NB keeps throwing objections. Ideally, I don't know if this is feasible, but one thing I've always been saying is NB could be made into a central medical university with the power to grant degrees, so that if you're affiliated to NB university, then your qualification, students get a qualification that is MD, MS on par with other institutes, so that there's no discrimination. So I think that brings me to the end of my, Before I finish, sorry, I'd like to put a shout to ANBI. ANBI is the Association of National Board Accredited Institutions. So if you're an NB accredited institution, you should definitely join ANBI, because they are the voice of all the institutions, and they have excellent relationship with the National Board of Education, and they brought about a significant amount of changes in dialogue with NB, that NB now entrusts ANBI to do a lot of affiliated work. So whoever, if you're NB accredited institution or thinking of getting accredited, you should join ANBI. That's the website, and it's fairly straightforward. So thank you, and if there are any questions, I think that brings me to the end.
All right. Thank you, Dr. Suresh. It was a detailed presentation on the process involved in DNB accreditation. Having done yourselves, thanks for sharing the intricacies and the hurdles involved in the accreditation. It was really wonderful, and I hope it's very helpful for all the audiences who are planning to start up the hospital. So may I request the panelists, Asha ma'am, PV Ramarao sir, and Maya sir, to share their thoughts. Firstly, I would like to ask Asha ma'am, if you are there.
So thank you very much. It was hello, can you hear me?
Yes, ma'am. Yes, ma'am. Go ahead.
Sir, Dr. Ramarao, it was an excellent session, and you brought out all the intricacies of the DNB accreditation and the new nomenclature. Recently, there's an association on the Facebook, DNB Doctors Association, and they were wondering about this new nomenclature, and they would be very excited. They asked me to send a screenshot, and I immediately sent, and there's a lot of response. So before I go on to whatever things I have to say, just 2-3 minutes. Prashant and Dinkar should be congratulated for making my beloved student, the shy Shivshankar Digikar, has bloomed into a very mature academician. They seem to be, I mean, what I like about this NNF Karnataka series is they're catching all these fellows young, training them and making them leaders. And you know what, Shivshankar, just before he left to UK, he came to Indira Gandhi, sought my blessings and went. I've been watching a lot of Mahabharata and Hara Hara Madeva to get over the gloom of COVID, and they say my samskara and samskruti. So I'm very, very proud of Shivshankar. And nowadays, what is happening? The wonderful relationship I have with my students. The only investment I have made is in my students. But I'm sorry to say, between the teacher and the student, we have got all this Google things coming up, PDFs coming up, and there is a lot of hyperskilia. And I have the experience of being a DNB teacher in 2 institutions post-retirement. One was a district hospital. I want to desperately work in a district hospital and a government institution, and I went there and it was pathetic. You know that you have people, sir showed us even your income tax from Form 16 to Form 26A, etc. There are faculty there just because of their MD and 8 years experience. They are taken as faculty. National Health Mission is paying them very good salary, but I could never get to see them, cannot make them research oriented, and they have linked up with a medical college ethical committee. It's all very messy, sir, though we feel DNB is so good. This is a situation in district hospitals where they have a senior consultant and a junior consultant. The senior consultant must have lots of experience, whereas a junior consultant with just 5 years of experience is taken post MD, is taken as a faculty. Recently, one of my former students who retired, she came to me and said, ma'am, can you give me a certificate saying that I taught? All her life, she has worked as a deputy director in government institutions, and she has been taken up in a district hospital as a DNB faculty. You know, they don't even know. When I said the new Nelson has come, she said, is it so? So government run district hospitals, DNB, though on paper, sir did mention it is very good, but unfortunately, it's very pathetic. There's high volume of patients, absolutely no training, faculty don't know anything about ethics and research. And as far as the corporate hospital is concerned, Dr. Maya and myself were teaching there, and Dr. Maya would leave and I would enter. He would say, I'm fed up of this laptop teaching. Just like your clinical skills, clinical sense and prognosis apps, you know, we were just putting up case scenarios and teaching them. They have no exposure to the kind of patients. The last week when I told you what National Health Education Policy with specific reference to medical education is looking at. We want doctors to run our primary and secondary healthcare institutions, but the corporate DNB trained people do not know what is IMNCI, FIMNCI. Dr. Rekha was talking about, she gave a lot of emphasis to KMC, etc. Unfortunately, no such thing is happening. There's a lot of teacher ethics and teacher deficiency. Okay. So these are a few of my points, and I must congratulate again Prashant and team for a sustained, sustained excellent program, excellent faculty of good quality right from the day of lockdown. This is one thing which I'm very happy about the lockdown and the COVID pandemic, while the rest of it is very gloomy and pathetic. Thank you so much for giving this opportunity. Shivshankar, way to go. I'm very, very proud of you.
Thank you, ma'am. Thank you so much. Thank you for sharing your thoughts as well. Can I request P.V. Ramarao, sir, to share his thoughts on the first topic of CPD, continuing professional development and its importance, and with a couple of questions to you as well, sir. So could you please share your thoughts on that?
Yeah. First of all, thanks to Dr. Dinika and Dr. Prashant for giving me this opportunity as a panelist. I think it was excellent talk and a very informative talk. Dr. Swarna Madam's talk. As we discussed, the academics are very, very important. I'll just give you an example, ma'am, very quickly. I worked in the UK for so many years, and after that, I settled here. When you go for the consultant interviews in UK, after finishing your training in UK, that's a CCT, Certificate of Completion of Training. That is 8 years training in the UK. I think you might be knowing that. When you apply or when you attend the consultant interview, so what they would concentrate is they would concentrate on the non-clinical things, because they would assume that once you're being shortlisted for the job, consultant job, that means your knowledge and your skills are kind of up to date. You got everything. Clinical part is sorted. You got those things. So they want to ask you about the clinical, clinical questions, ma'am. They will ask you about the academics part. That is non-clinical things in academics. About your teaching, about your training, about your leadership skills, about your admin skills, about your managerial skills, about your communication skills, about your audit research, etc., etc. No, they would concentrate on those things. If you are really, really good with those other non-clinical things, then only you would get the consultant job, man. You won't just get the job because you were trained in so much, kind of central institute. You have gotten so many years of experience. No, they won't give you the job. Unless you have other skills, other non-clinical things, which you have discussed, elaborately. It was really, really very well done, man. The other thing is about the UK exams. I'll very quickly tell about that. MSc exams. MSc UK exam for the past 10 years. In that, the important one, so the in ASCII, there are 10 ASCII stations. In that, 2 of the ASCII stations are communication skills. So that means the communication skills are so important. So, our education system is good. I'm not commenting or criticizing our education system in India, but I think there are some changes to be made in the education system, because their approach and their way of dealing things, and they would also give importance to others, other non-clinical things which you have mentioned. Very quickly about other things, one is, what I feel is rather than having talks in the CMEs, in webinar meetings, it's better to have more of case-based discussions, because nowadays, most of our practicing pediatricians or postgraduates, they would be interested in case-based discussions rather than in kind of giving lectures. So I think I would definitely suggest to all of our teachers and all of our consultants, you've already been doing it, but I think it's more of case-based discussions and more of master classes, and those things would be really, really useful to the practicing pediatricians and also postgraduates. And the other thing is the motivational class for doctors and nurses in hospital. That's really, really good, man. You discussed everything. That's really, really useful. In that, the important things to add on is the thing is how to inspire your juniors, how to inspire your staff, and how to empower others, and then how to strategically influence others, your staff, your juniors, your staff, your colleagues. That's very, very important. And finally, in that, integrity is very important, man. If you all have integrity, and of course, we will be definitely be a successful doctor. And a few add-ons very quickly. The non-clinical teaching, which are already discussed. In that, there are 2 things. One is about the good clinical care, and second thing about the good medical practice. So there are quite a few doctors. They're kind of very good at clinical care, but when you look at the other part of the thing, so that is good medical practice. So that good medical practice include good working relationship with the other parents, staff, colleagues, and children, and then you have the good team player and good leadership skills, good time management skills. As you know, all those things are very important. Some doctors are they're really very good at clinical care, but they're not that good at good medical practice. I think in our teaching in our teaching schedule, we also need to include the good medical practice things, which you have already mentioned, in addition to the good clinical care. And finally, I would like to end my discussion with supporting professional activities. As Dr. Suresh mentioned that every faculty, every consultant, every teaching hospital or NBA accredited institution consultant should spend at least 8 to 10 hours on teaching juniors, teaching staff nurses and teaching other junior colleagues. So in that, teaching, training, audit, research, and also to actively involve in the guidelines development. Because I'll just give you an example. I called one of the doctors, one of the pediatricians to come for interview for a job. She did quite well in the interview, but when I asked about the audit, she hasn't got a clue about audit. She doesn't know what's audit about. So I think these things, as a faculty, as a consultants, as a teaching institute, faculty, we all need to concentrate on the other aspects of academics, which you have mentioned, in detail. Thank you. Thanks to all. Sir, I have a quick question for you, Dr. Suresh, sir. Regarding MRCP-CH, the NB is considering MRCP-CH, or if you have CCT in pediatrics in UK, whether they are considering that one as a faculty or not, sir?
That's something that they have not clarified because, for example, personally, we have a consultant neonatologist who's an excellent teacher and he's MRCP-CH, but he went to the type 2, I think they call it type 2 rota, wherein he didn't go through CCT, but he was at St. George's, England. He was a faculty there. And he's been rejected when we showed him as a faculty, and it's one of the things that's been ongoing. So he's got registered with the MCI. MCI accepted him, given the additional qualification registration certificate. But when it went to National Board, they didn't ask for CCT. What they're saying is, we are not finding evidence of any thesis in your training program, so it can't be accepted. And as you know, MRCP-CH does not have a concept of thesis. You do research after you complete your MRCP-CH. And we tried showing research activity, etc. But the same thing, like I said, they can be very bureaucratic, and they came back saying, no, there's no evidence of thesis, so he can't be a PG teacher.
Sir, sorry, sir. One more additional question. Are they considering CCT, sir? CCT, for example, in pediatrics, in UK they give the CCT after.
I know what CCT is, but frankly, I don't know because they have not they don't say give me a CCT. They just saying equivalent qualification. And when I ask them for clarification, saying what do you mean by equivalent qualification? Why can't you accept this? There's not the only thing they're saying is thesis. They have not said that we want CCT. And I've looked through other institutes that have, because you can go to the National Board website and see each institute and what is the faculty. And in some cases where, for example, someone's got an FRCOG from MRCOG FR. So they're accepted when it's FRCOG, but they're not accepting it MRCOG. So maybe they're not clear as to what these degrees are. And I really don't know whether CCT is, if you give a CCT, they'll accept it.
So suppose if you have fellowships, sir, FRCP-CH, do they accept rather than MRCP-CH?
They didn't accept it, and I'm a member of ANBI, and we're planning to apply for neonatology this year, and we're going to use ANBI. ANBI said they'll support us, saying that yes, they should accept it, and we're going to use ANBI, which is the association, to I like to say fight it out, but have a dialogue with them. We've spoken to the NB president, and he's also said supported, because it was 2 years ago last time we applied. This year we're applying, so we'll know what happens.
Okay. Okay, sir. Thank you, sir. That really helps.
Thank you, sir. Can I request PP Maya, sir, if he's there, to share his thoughts before we go on to the questions? Maya, sir?
Kindly unmute and speak, sir. Mahesh sir, kindly unmute and speak.
Okay. Can you hear now?
Yes, sir. Yes.
Hello? Okay. Anyhow, thank you, Dr. Prashant, for including me in this webinar series. It's a proud privilege, I feel, to express my views and then the experiences. For DNB, I think I've been in DNB for nearly 20 years. I gone as an inspector, and also I was on the receiving end also. So I know the experiences as an inspector as well as from the receiving end. So I would like to congratulate Dr. Suresh for giving an excellent presentation. But still, there are certain things as an inspector and also from the receiving end, I thought I would like to share with you. One is as a teacher. Teacher is the most important thing. Qualification, and it should be dedicated only to the DNB of that particular institution. You cannot have any other appointments anywhere. They will check the salary certificate, as you already said, and they got a website. They will find out where all you have got entry into that particular institution. So that is impossible now. And the second is super specialty consultants. Super specialty consultants are necessary, but they are not considered as teachers for the DNB training. Because many times we include endocrinologists, pediatric endocrinologists, and even neonatologists, but they may not be considered as a teacher for DNB pediatrics. That is another important point. And salaries of the teacher, many times in the DNB institutions are mainly from the smaller institutions. Example, 100 beds or 200 beds, where there are multiple the specialities, wherein you have got teachers, only they come as consultants and go out. But the actual teaching is done by a person who is appointed directly by the institution for teaching purpose. For this, they expect more salary, DNB. But unfortunately, they are paid little less. When the inspector comes to know that your salary, the first thing he will ask you in private is that all the salary you are taking home. This again puts the institution into trouble. This is another point. Then the maximum age, I don't know how it is now. I'm still continuing to be a DNB teacher in Sagar Hospital. I don't know when I'm going to be out of it. This is another point. Second, the basic sciences. Yes, earlier they used to give a lot of importance to the basic sciences. You have to send the students to these particular designated places. And if you don't have, and it's a drawback, and you'll have a lot of queries. But now they relaxed a bit, and these basic sciences can be taught even by the regular teachers also. And the BEX is always a problem. This is about the teachers. Second is the patient load. This is where the most of the institutions get into trouble. The smaller hospital like that, what I said, they may not have enough patient load for teaching. As you already said, 30 beds designated only for teaching and training of the DNB students, which is a problem in majority of the corporate hospitals. Private room patients are not considered for the training beds. So this is another place wherein the institution gets into trouble. Before they call for inspection, they should see that everything is in place. And split beds, I would like to ask Dr. Suresh, So if you have this one 30 beds, if you don't have in one particular in one particular hospital, you have another this franchise or whatever it is in some other place. Can you include those beds also, which I am not very sure. Next important thing is the library. He has already emphasized very well, but majority of the places, they get into trouble by the inspector for the library facilities. One is the foreign journals, two foreign journals is a must. Indian journals, they should have it. And they should have enough place to run the library, and we should have a place, I mean, it should be shown to this particular inspector that students are borrowing the books and returning the books. They will check the registry of the library. Again, these are all certain minor things. Probably those who are respondents, they should be very careful before they call for the inspectors. And next is the thesis. Thesis guide. Earlier, yes, we should have the people with the postgraduate training experience can only be thesis guides. But now it's changed. To my knowledge, those who do one thesis, they are eligible as a teacher, and they can guide the subsequent thesis. The first thesis is important for the people who are in the department. Next is accommodation for the postgraduate, which I already emphasized it, but I'll tell you my experience. It is not just the accommodation being shown in paper. They require the accommodation. Where exactly is the accommodation? How much rent is being paid? How many rooms are there? If the food is available, all those things will be inquired before they go for the final certification. And ICU beds are generally not included earlier. Now I don't know whether the ICU beds are included. And when the inspector comes to inspect, he has got a separate session with the postgraduates who are being trained. This is a very important session. I can only tell my experience. About 3-4 years back, when they came for the inspection, they looked into the patient facilities, which was obviously not really that much sufficient, and they went on bombarding. This is my experience. In the morning session, inspectors generally bombard. After lunch, generally they cool down a bit. That's where probably you have to put your all effort to convince the inspectors. They will have a separate session on the DNB students, wherein they will cross-check. For example, we have all the presentations or the PPT presentations. They're all in a pen drive. He took the pen drive and then saw all the sessions and started asking the questions to the students. And they asked, in the last 1 week, how many sessions you had, teaching sessions? They couldn't believe they had 5 teaching sessions. Then they asked them to show it on record. So they have to show their logbook. They have to show in their own PPT laptops. So this is again, one should be very careful when you are asking for the inspection. And yeah, these are some of my observations for DNB accreditation. Yes, the most important is the record system. Many people are very crazy about the record, the inspectors. The first thing they go is for record system. They'll try to find out the international classification system is there not, how they code these patients and the diagnosis, and how many outpatients, how many inpatients in the last 1 or 2 years. They really cross-check it, so one cannot fool it. It's very important again, because I have experienced many, this MCI, the inspections as well as DNB inspections. Once you start fooling them, you will be doing a lot of mistakes. So that the best thing is to see that everything in record and it's all properly. About Dr. Swarna Rekha's presentation, very nice presentation again. I would like to say again a few words about it. Dr. Prashant was asking about the benefit to the institution, benefits to the individuals, and benefits to the students. I can give you an example. When I was leaving St. John's, I think in 1985, the director, Father Percival Fernandez, called me to his room and told why I was leaving. So I have to tell them there's nothing here, no, nothing is moving. He said, no neonatology, which I'm very keen on starting. He said, I'll pay you 1.5 lakhs for the neonatal setup. Those days, even 1.5 lakhs is not covered by the Vickers, the open care system. So he asked me how you can improve the department. Those days it's not like the current St. John's. We used to have only about 30, 40 outpatients. I'm talking about very early 1980s, shifted from St. Martha's to St. John's campus. And postgraduate was the first postgraduate batch I had. So he asked me how we can improve. First thing I told him was it to conduct the CMEs. You do not have place to conduct the CME. There's only one St. Ignatius Hall. It is used for undergraduate classes and CMEs for everything. He said you must have a separate place for CMEs to accommodate more people, to tell the Bangalore people that St. John's is doing much more than the other institutions. So I was very much impressed. This is my first priority, he said. And second thing is that ongoing education. That also, yes, we was very much impressed upon that. That also we must start it. For the students, all the CMEs are going to be benefited, which you all know about it. And for the institution, it's a sort of advertisement. All the Bangalore city people used to go to St. John's for repeated CMEs or workshops and all that. Is again a credit to the institution and to the department. One important thing about department is, I remember in St. John's, around 4 o'clock, the medical superintendent used to go around the whole hospital. It's very interesting. Dr. Sarnaleka may not be knowing that. He used to check which are all the doctors have run away from the institution before 4 o'clock. So this is the cross-checking going on. So what we did was, all the teaching session kept it in the afternoon. Went on till 4 o'clock, so that nobody can leave the department before 4 o'clock. So it's a bond for the teachers also to stay longer in the institution, what they are paid for. This is another very important aspect in the beginning of any of the departments who start doing this post-graduation. I remember in Ramaya also, I didn't have the post-graduation for the first 2 years when I went. We used to catch hold of the interns and then having a session, seminars, care discussion, everything in the afternoon, to keep all the faculty in the institution as well as to have some amount of teaching going on. Next is about the rounds, he said. It is definitely true. The postgraduate department is recognized by its rounds. I remember of taking a round from the morning 9 o'clock till about 4 o'clock continuously on a post-admission day. This is actually I would feel that it is a very important thing, so that patients get benefited. Every new case is being discussed with the postgraduates. All the postgraduates have to present the cases, and all the cases are being discussed. This is helping in the diagnosis as well as this management. So by doing this, you have the definite advantage of raising the standard of teaching as well as the raising the standard of the treatment to the patients. So teaching ground is again important, and I think she has discussed many of those workshops and other things in a very detailed fashion. The only one I would like to say is very important thing is for the person who takes care of the department, he should have a leadership qualities. He must take all the faculties with him to develop all these things. Unless you take all these people with you, you will never be able to succeed in doing any CME or any this one teaching method or the teaching sessions and workshops and so on. So these are some of my views and experiences. I think I posed two questions to for DNB. One is on the split beds. And second thing is, again, yeah, one more very important thing is the statistics. I think he has not told about statistician. Statistician is very important. We always ask for statistician. I always used to ask for statistician. He should be a full-time man, and he has got a statistics department, and he should be guiding the students for thesis statistics. So statistician is also very important in the DNB training. Thank you very much.
Thank you, sir. I think whatever experience you shared wouldn't be available on any journals or on the books. So it's really helpful for most of us. So is it okay to ask a few questions, ma'am? Swarna, ma'am?
Yeah, please.
Can I answer the two questions that he asked just now?
Please go ahead.
Yeah.
I'm sorry. Yeah, please go ahead. Yeah.
So I think the age for retirement is 75 now, according to the MCI norms, which National Board also follows. And split facilities is specifically ruled out. I mentioned that in my slide. And you cannot combine two facilities, either sister institution, your own institution. It all has to be in one campus. And you're right about statistician, but somehow I was just looking at the latest application, and earlier they used to be specifically saying that a statistician should be there, but the latest one, that line is gone. So, but part-time statisticians are allowed according to NBE. Thank you.
All right. Thank you so much for clarifying it. So, ma'am, with regards to motivation,
Yes.
in an institute, there are various stratas of professionals like interns, PGs, fellows, and the faculties as well. And they're going through various stress, personally and professionally. And with regards to teaching, how easy it to motivate them to come to teaching? Is it very difficult, or how difficult it is to motivate them to come to teaching programs every day, or is it compulsory or anything?
Okay.
Yeah.
It just is the amount of discipline that you create in the department. I'm not saying it's easy. I'm not saying it's difficult. But if the head of department or the senior faculty comes and sits in the teaching program at 1:55, when the teaching program starts at 2 o'clock, automatically these students will come in. But if the senior faculty come in much later, they're going to take it lightly. If there is no feedback to them that, look, you have not turned up, you have not done this, you have not done that. If there is no feedback and say, oh my God, poor kid, he's stressed out, he's got work, she's got work, she has to go back home. And if we start this poor thing concept, you're not going to get anywhere. But at the same time, I do agree that the stress levels is much higher, not COVID. Without COVID also, the stress levels are very much higher. And as senior faculty, we need to factor this when we are handling students and junior faculty. Very simplistically putting, I remember in our earlier days, we used to pull up residents on rounds. why was this not done? Why was this not done? There's no way I could do it in the later years in St. John's for the simple reason it would become medical legal issues. Patients were more aware, and there's no way I can. Plus, the sensitivity of the students were much more. They wouldn't take it. I mean, all of us have stories of how we have been treated, but it doesn't mean that we need to treat our students the same way. But it is important to instill discipline, but at the same time be supportive. And the way we worked it out was that if one of us was strict, one of our junior faculty would sort of handhold and say, all right, fine, it's okay. And I think there has to be a kind of mentorship which has to go on in these institutions, which is more than just training, which is hand-holding, which is listening to their stress, those kind of things. So I think that also is extremely important. So my answer is it's not impossible. It's not easy. And there are two things can happen. One motivated student can motivate everybody, and one unmotivated student can demotivate everybody. So we need to be careful of these outliers, promote the first kind, and ignore or do something about the unmotivated. And again, it's very easy to say, but I think being a role model is the most important.
All right, thank you, ma'am. And having worked in St. John's and Narayana, is it any different to put the teaching rotas in two different setups? Was it easy in St. John's, or was it more difficult in Narayana, or is it any better?
No. I mean, just like what Dr. Maya said, see, when you are in the so-called teaching institute where you have even NH, there were students. There were DNB students. There were fellowship students. But the culture in a medical college is a little different because it's understood that these training programs go and there is a certain priority as a culture to these students. So like Sir said, always teaching programs would be in the afternoon. Some of us would have it early morning, 8 to 9 or whatever it is. And there was a hierarchy of people who were looking after patients. So patient care never suffered. Whereas in a corporate hospital, the issue comes that patients come to your name and not necessarily to the institution. So your primary responsibility in a corporate hospital is to the patient. Whereas in an institution, which is sort of academic, possibly, I'm not saying people don't come by name, but they come to the institution and there is over a period of time, they start coming only to that person. So your availability in a corporate hospital to the patient care is primary. So therefore, organizing teaching programs would become a problem because in NH, the OPD would start at 8 o'clock and continue till 4 o'clock or 5 o'clock. So it has to be in that lunchtime period and invariably people wouldn't turn up. But fortunately for me, I don't know, the postgraduates would turn up. That was good enough for me. I was okay if the students didn't turn up. The postgraduates, the faculty wouldn't turn up, and not for any reason. Two reasons. One is it was not a habit.
True.
And two, the presumed thing is my commitment to the patient. Because I'm sure you can always get around it and say, look, do not give me, today is my teaching day. Do not give appointments between 2 and 4. As easy as that. But then you have your HR department saying, no, sir, no, ma'am, how can you, etc., etc. So there are issues. So we need to work around it. And I'm sure we'll find solutions, and the solution is going to be different for different institutions.
Sure, ma'am.
Okay.
Thank you. And just one final question is about the credit hours. Since MCI has introduced these credit hours as CPD credit hours that you need, and 2011, if I'm not wrong, you need to have 30 hours of credit hours in 5 years. And if two states have mandated it for registration. So do you think that is it, the CME just should go on credit hours, or it should be just an act which should go without that?
All right. See, the thing is that, like I said, right, during my presentation, that we have all learned on our job. But as I see in the last 30 years, unstructured training is not that acceptable or assimilated as structured training. So things are becoming more and more complicated in terms of, unless there is a rule, nobody follows it. Okay. So to that extent, these credit hours is good. At least it gets somebody to do minimum basic stuff. But I think that is just one part of training and teaching and things like that. And I think the larger part is more important, that you continue to do it because you want to grow professionally, you want to grow personally, and those are the motivated people who will do it. The ones who are doing it for the sake of doing it are doing it for the sake of doing it, and you can't change them. So let that group be. Let's continue to do things for those, whatever percentage of people who love to learn and who love to improve. All right?
Sure, ma'am. I think as a professionals, we the medical profession is ever changing, so it's our prime responsibility to be updated for improving the patient care. So the next question is to PV Ramarao, sir. Are you there, sir?
Yes, I'm still here.
What would you tell a person, like if he's setting up an institute which is non-teaching, how to go about starting a teaching schedule or CPDs in just to begin with, because the institute has been started today. So what all we should do to start a teaching program in that institute, which is not a formal teaching institute, to begin with? Yeah.
Okay, so to begin with, first of all, you need to have teaching faculty, who are interested in teaching. That's number one. And number two is so you need to appoint, you need to identify one of the consultant faculty who has got interest in teaching. Appoint that person, that consultant, as a teaching coordinator. And then formally you prepare the teaching schedule. So in that teaching schedule, we should include regular teaching sessions. Apart from the regular teaching session, you need to include like one audit and one journal club. So like that, you need to have a variety of teaching. Teaching scheduled topics, not just a kind of clinical based teaching. The others we should include audit, research, and the general club and guidelines development. Like that, you need to divide the teaching schedule in such a way so that it will be interesting to the postgraduates. So I think the answer to your question is, first of all, you need to identify one of the faculty who has got interest in teaching and appoint him as a teaching coordinator, and then design the teaching schedule. And then to go over it, and once we start the teaching schedule, wait for a couple of months or so, and then do the audit to know how we are performing, take the feedback from the junior colleagues and postgraduates, and make changes, and then take it forward. That's what I will do.
Sure, sir. Thank you for answering that question. Dr. Suresh, you have got one question. If a person has started as the institute today and it started running from now, how many years or months he should take? I mean, for getting a DNB accreditation, how far he should look? How many years he should look to get a DNB accreditation if you started today?
The current guideline says that you have to have completed 1 year of clinical as a hospital before you can apply. There is 2 years by the time you start the program. Okay. So 1 year after starting your hospital.
And from your personal experience, how difficult was it for you in a couple of sentences, a roadmap of your experience in a couple of sentences, please?
I mean, we've been running DNB programs for quite some time now. And earlier, it used to be very difficult. The application was archaic and difficult to interpret. But today, I would say it's very straightforward. Download the application, the requirements, criteria, everything's very clear. For example, initially, one of the things like pediatrics and super specialty, even there they say pediatrics 30 beds requirement. 15 should be for general pediatrics, another 15 can be for other pediatric specialties. That way, the application information booklet is very clear, it's very straightforward. So I would say, as long as you have the requirement in the information booklet, it's straightforward, it's easy to do. Everyone can and should be on board.
All right. Thank you so much to both of the speakers and the panelists. Any final questions from the audience? It's open for a discussion again. Final questions before we wind up the session.
Just one second. I just wanted to say that the most difficult thing about applying for any of these courses is convincing the management, unless you yourself are the management. Because, you know, there is nothing for the management in it except that they have to pay stipend. Unlike the MD, DM programs, where the fees are much higher, here it is restricted. So the biggest hurdle, once you have convinced the management, is not impossible to do.
Dr. Suresh himself being a managing director, any thoughts on that? Any different thoughts on that?
But I do.
Yes, ma'am.
I just want to add one more point. Last week we spoke about the fellowship programs and all that. So Indira Gandhi became an NNF accredited level 3A center, and from NNF they sent a student. Okay, and the whole issue was who will pay stipend. NNF does not pay the stipend, and in Indira Gandhi I did not have any provision to pay the stipend. Subsequently, I converted him into a senior resident, and from that we tried and paid the stipend. So these are some issues when you try to get your centers accredited and you try to do something in the government hospitals.
Sure.
That's it.
Yeah.
So,
yes, Dr.
Yeah,
Suresh.
I mean, what Dr. Swarna said is true. I answer to the board, and not just the board. My CEO sometimes
to answer that.
Even my CEO sometimes comes and say, how can you justify DNB? Because like I said, there is a cost to the program. And unfortunately, the fees are quite low. Whereas if there's little flexibility on the fees, at least to cover the costs, it definitely would go a long way in running, more institutions coming on board. Because compared to the future earnings and the kind of training that we give, the fees at 1,25,000 is really, really low.
All right. I hope that's sorted, ma'am. So I think we should wind up the session. Again, thank you for Swarna Rekha ma'am and Dr. Suresh.
You have a question before we close. I saw Dinakar sir, Kishore sir.
Dr. Suresh.
Yeah.
We can hear you, sir. Go ahead.
I think so. Suresh can hear. Yeah, Suresh, you are telling us. So once your hospital is completed a year, later you should apply. Then after next year, means 2 completed years, they will come for the inspection. It's very clear in your words.
No. You apply 1 year. The assessment and inspection process takes 2 years, and by the time you get your accreditation, sorry, takes 1 year. So you apply
No, we didn't get
after
you.
1 year. No, you can apply after 1 year. In the next 1 year, they process your application, come for assessment, and by the time you complete 2 years, you will get approval to start the program. 2 years.
Totally 3 years.
2 years.
No. 1 year before you apply. 1 year for the application, the whole accreditation process, rather.
Okay. So when they will come for the inspection?
Within the second, after you apply, within 9 months.
Within 9 months they will come. So my one question. Second thing, it is written, you told. So Dr. Mai is included. Then so in 100 bedded, suppose if you are applying for the pediatrics, 50 bedded. Suppose if you are having ICU, 25 bedded NICU. So 10 bedded or 15 bedded pediatric ICU. So that will come around 40%. Another 60%, that means 60 beds, we are supposed to show the pediatrics case. So is there anything in that 60 bed If it is an pediatric hospital, single room, double room, or general ward, is there any divide is there or anything we can show?
No, they only go by number of beds, so they don't specify general ward, single, double. But if you can show 30% general ward beds, it's easier to convince the assessor saying that yes, these are general ward patients, which my PG students will be have access to. Otherwise, they will definitely ask. You're saying all single rooms, and will the patients be comfortable with PG students coming and treating them? So when you say 30 beds is enough. Like I said, for pediatrics, 30 beds is enough. Pediatric guys, if you want to do DRNB, pediatric critical care or neonatology, 10 beds. So you're well within limits. But when it comes to pediatrics, do have at least 10 beds as general ward, so that can be shown as training beds.
Yeah. So my next question is, Suresh, for you. Is there first we should apply for the DNB pediatrics general, later for the neonatology? Is there any criteria like that?
No, you can apply for all together as long as you have the bed strength, the caseload, and faculty.
Yeah. So for that 2 years, we should maintain the register.
You should
Means
maintain
how many cases and that.
1 year at the time of application. And
no. Just for inspection. Initially, I am talking about, madam.
Maintain the register always, boss. Documentation is very important. Documentation.
Okay, I got it. My next question. Dr. Suresh, don't feel bad. You told, and Maya sir was telling, regarding the hostel facility, you told accommodation 20,000. Nowhere on this earth, even in the village, will give for 1 year accommodation 20,000. Very clear. And number one. Yeah. Number second, Maya sir was telling they will come and ask, they will come and inspect the accommodation. Accommodation means staying. Is there anything food also we should give?
No. No. Food is not part of the requirement.
Okay. No, because if it is DNB, if it is even diploma, even male will come, female will come, we should give them separate hostel. So that is the reason I am asking. Because males, we can take one house. If it is in the periphery, please go ahead.
What we've done is within walking distance, we've rented a couple of apartments, 2-bedroom apartments, and we've given them on sharing basis, 2-bedroom apartments, so 4 people can stay in the apartment, and we make sure that only boys or girls are in one apartment. That's all. Yeah. So sometimes there may be 1 or 2 beds that are vacant.
Can I make a clarification?
So food, no, because in case if they will come, who is giving food? No, is there no criteria? No.
No, food is not a requirement.
Okay. Only shelter.
Only shelter.
Only shelter, but what is more important is it should be near the institution. As I'm aware that if you are providing some kind of an accommodation, preferably it should be near the institution so that they can come.
It should be within 5 kilometers of the institute.
That's
okay. And madam, and for Suresh, one more question. You told library should be there. Okay, books we are going. So one after I'm going to apply. From that time, we have to maintain that library, that journals and books, or at the time of inspection, we should provide. When they, because Maya sir and you told me they will see the bills. Exact question answers.
Earlier, okay, it's a good question because earlier you had to have the subscription at the time of application, and that was a cost again because for 1 year you are subscribing it if you are not using the books. Today, they very specifically, National Board says that you do not need the subscriptions at the time of application, but the assessor, by the time the assessor comes and the final accreditation comes in, you have to have all the proof.
So, do you think they will inform us 1 month earlier they are going to come?
Yeah. You get adequate notice.
Or like a MCA inspection, suddenly they will come and sit on our head?
Not yet.
Not yet.
Okay.
No, you give you have adequate notice. The assessor is informed at the same time as you, and you talk to the assessor and fix a time within a window. So that you are given like a 2-week window. I mean, basically, you have about 2-3 weeks time for it.
So Maya sir,
Yeah.
I wanted to make
And
a
one more thing, Suresh, you are telling,
No.
and I am asking you for the madam also. The DNB accreditation money you showed in your thing is 35,000 to almost 40,000, 30,000, 33,000, then for 39,000. But you have put a once again cat on the wall. Why I am telling is, you told very clearly, but on par we have to pay. You told that word. Then you told the next word, Tamil Nadu is giving like this, I am paying. We didn't get it. Because the rules is rules. When for them rules DNB, for us also whatever they told we have to pay. About that, very clear, crispy answer.
Simple. Whichever is higher, DNB guideline or your state government guideline.
Okay. Okay.
Hello.
Madam Asha, guidelines.
Hello.
Asha, madam.
Yes. Rapid fire down.
State government guidelines as to the minimum.
No, same thing. Hello.
Yeah, you are audible. Yeah.
What is the state government
It is
guidelines?
not separate for state government. It is not separate for corporate hospitals like that. Sir has very lucidly put across all the bed strength. So it is not that you have a separate thing and all that. The only problem in district hospital Tumkur where I worked, they did not have an ethical committee, they did not have library, they did not have the latest journals, they did not have accommodation. So everything is taken care by the National Health Mission. So somehow they managed to get it. They are very lenient.
No, madam, Kolar also they got a DNB, OBG. They are not having anything, whatever it is there. Since it is government, so they have given. But when we starting private, everything they will ask.
No,
They will ask.
one
No.
thing,
Why I am telling is after a next year, exactly after January 2021, I am going to apply. Because it is 160 bedded hospital, I am going to apply. That is the reason my questions are genuine and crisp.
Yes.
So is there anything around the 50,000, 60,000? How much I don't know. No.
As far as the present institution where I'm working, we are 1 year now on November. So we are already started the process of applying. And simultaneously, we are doing NABH because it will streamline many intricate details of DNB accreditation.
The government publishes a GO giving the state government what is the stipend for PGs in state government hospitals. So you take the DNB guideline, whichever is higher, you pay. Simple.
Asha madam, how much? Asha madam,
35,000 first year. 30, 35 and 40,000.
Okay, madam.
In district hospitals, the senior consultant gets 1.5, junior consultant gets 1.3, and they should have the junior consultant should have 8 years post MD teaching experience. Senior consultant should have 10 years PG teaching experience. And they should stay in the house. Dr. Swarna, Maya, sir, Dr. Suresh, they all stressed that the faculty should be in house, but it is not like that at all. Very sorry to say that things are not as rosy or as good as it appears on the DNB papers.
No, for district hospitals, there actually is a relaxation saying that district hospitals can combine with the medical college and show infrastructure. So one of the questions was, can we combine infrastructure? That relaxation is given for district hospitals alone, government district hospitals, not private.
Yeah. So Suresh, there is one question for you. Please don't get upset. Number one, no, because I'm asking you the things because you are running that institution and you are a successful man. So that in that DNB and you, I know that about you, how you are running it. See, regarding the DNB and regarding the, what is it? See, once we apply, once they come, accommodation, everything is there. Is there any agency, A and B, you are telling? Once we apply, do you think they will help us to get the DNB? They will rectify anything like NABH? There is so many agencies are there. to get
Okay,
NABH.
let me clarify. Let me put a stop straight away. The DNB application, there's a line which specifically says that application should be filled in by the hospital or employee of the hospital. You should not use any third-party agency or you can say contractor to fill in your application or help you with it. It has to be done in-house. There is no consultancy, etc. for DNB. And DNB, if everything is in line, you will get DNB. You don't have to worry about anything else. The application form is very clear. And one more clarification, like you said, you're going to apply in 2021. In January cycle, you can only apply for basic sciences, which is pediatrics. Neonatology will be coming only in 6 months later. There's a 6-month window difference between super specialty and basic specialties. But no agency, you have to do it with your own staff. That doesn't mean you can't ask a friend, or if I can be ask me assistant, I can help you, but on an informal basis, but no paid agency.
No, we got it. Then one more thing. Suppose medical college professor, he is going, and Maya sir was telling very crisp, clear. Form number 16, they are going to check where and all he is going to get the money. So it's very difficult to cheat. Suppose my one consultant is going to the medical college, or he might have given his papers for the inspection sake. Do you think but he is not at all going only for inspection. Whatever I am talking, you know that everything is going on, whatever I am talking on this earth. So do you think they will come to know that in the medical colleges for the inspection sake, they will give that, and later, do you think like that people, can we take them for our DNB thing as this thing, or very strictly no, or yes?
No post faculty.
No. Okay. No. Very clear. That means he should not be attached to the any organization, any medical teaching organization.
Teaching organization or any other inpatient practice
can I
also.
clarify a bit?
Yes, sir. Yes, sir.
Yeah. Yeah. One point is on the beds for teaching. I think, to my knowledge, even any private room patients are not considered for postgraduate teaching. It should be general ward patients only, and they're all paid for the particular training. That is one aspect. Second, you said about the mess. Now, the whole principle is students should not run around for food. You should have some place to eat, preferably within the accommodation itself. Number 3, what Dr. Dinkar said, it's a very interesting question, but it used to happen earlier. But now the technology is so well developed, they will come to know that where all you are going. So that you cannot really do that is impossible. If you want to really take somebody, you must take for your institution only. And my simple advice is, I have faced about at least 20-25 inspections I have faced, and at least 5 times I went as an inspector. I know where exactly the people get into trouble. 3 important things you must know. One is a teacher. You should be really a teacher dedicated to your own institution, number 1. And he should be paid well. He should be paid in par with the other medical college teachers. Then only people will accept you, as probably you are definitely being taken here as a postgraduate teacher. Number 1. And number 2, probably for the this one teachers, they should be about 75 years younger, and they should also have accommodation there that they think about it, and we should be clear about it. That is about teachers. Second important thing which you get into trouble is a medical record system. Medical record system is very important. They go through each and every aspect of the medical record. And even though your specialty is pediatrics, our first round would be to go through the whole hospital, all the facilities available, like radiology and pathology and so on. All the departments, they should also be ready with their facilities available, number of tests being taken per day. All those things are important.
So the emphasis on biomedical waste management, apart from ancillary, auxiliary and support systems, They go into details of biomedical waste management.
Ha, madam.
I'd like to add one example. When we had a pediatrics assessment, the assessor, before going to the actual pediatrics, when he went on the hospital round, we took him to the blood bank. Immediately he went to the blood bank and he wanted to see how many exchange transfusions we're doing, how many, to justify saying that are we really our caseload? Because I mean, you can guess, as if you're an experienced person, you know, if you have so much caseload, you must be doing so many exchange transfusions, etc. So there are areas that they will look into based on their experience. Like sir said, he's got a lot of experience. So although it is not part of the national board assessment criteria, he said, I want to see your blood bank records and show me how many exchange transfusions you've done. So that way, they are quite smart. People who come in like sir are very smart, who've been at both ends, receiving and giving. That gaming the system is not advisable.
Yeah, I just wanted to make one comment. I entirely agree with what Dr. Suresh and what sir said. Generally, when you go as an inspector, there are two things. One is, like Dr. Suresh said, we tend to go around the hospital to look at all the additional facilities which are there, whether it is MRD, whether it is HIS system, whether it is blood bank, lab, etc. And we get an idea about that. The second thing is, I think from the institution point of view, it's a good habit to make a presentation. So usually that's it gives a, so the moment the inspector comes, you make a PowerPoint presentation about, I'm not talking about your institution, but I'm talking about the data, about whatever statistics, etc., which you have sent in the application. Then take them for a hospital round, and then they come into the department. So that way it works out much better.
Yes, madam.
Yeah, I think that what Madam has said is correct. In the sense, invariably in all the institutions, in the presence of all these some faculties, they will have presentations about the whole hospital. Then as the dean or the medical director or somebody takes them round, then ultimately they will be handed over to the departmental chief. I think that is a general routine which is being done.
The thing is, Dinika, Dr. Dinika, addition there, brother. It's not that easy to get the DNB accreditation because I've gone through so many hurdles. Said Dr. Dinika. I'm not commenting about the DNB instructors. They're all really good.
Chapana. Hello.
Excuse me, sir. Hello.
Anna Ramarao Anna.
I think we just lost him. Connection issues.
Hello.
Yeah.
Good evening. Good evening, sir. I am Dr. Charul from BJ Medical College. I have a query. Actually, I missed the initial part of conversation. I have just joined in when I was just going through the discussion which was going about regarding the accreditation. We are in process of getting super specialty accreditation for neonatology in our institute. So I just want to ask, because we don't have a super specialist available in our institute. So we all are having more than 10 years of experience and we all are recognized PG teachers. So if we are to be shown as DNB teachers for super specialty, then we shall have to discontinue our PG teaching. We have to confiscate our PG degree.
So who would like to take that question? Dr. Suresh? Yeah.
Let me
it's very clear. They are telling you should not work in two institutions.
Okay.
They told very clearly you should not work in two institutions. You should give it up. Either if you are going for the super specialty, DNB, so you should forego the medical college. Even I am also in the same situation. I have to forego the medical college if I am starting my own DNB or super specialty DNB. That's what they are telling. Over to Suresh or Madam.
Yes, sir.
What was the question? You're starting super specialty in your same institution or a different institution?
Sir, in the same institute.
Okay, you can't be faculty for two programs except one or two. Like family medicine allows you to be a co-faculty in your medicine, pediatric surgery, and be family medicine. Otherwise, if you want to apply for neonatology, I mean, you can, while you're currently pediatric faculty, you can still apply. But by the time you get approved, you will have to give up your status as faculty in the pediatric program. One. Two, pediatric, as a neonatology, if I recollect correctly, the requirement is DM or equivalent. But they do have a caveat saying that in nascent specialties where there are not adequate super specialists as faculty, basic special like MD pediatrics can be considered, provided it can be justified with proof that you have been working exclusively in neonatology or the super specialty with proof of research and presentations, etc. So whether they will accept MD as faculty for DM, I mean PRNB neonatology, it's on a case-to-case basis by national board.
Sir, it is MD pediatrics and a fellowship in neonatology and a total experience of 10 years in neonatology. Because we don't have PM neonatology seats.
That's what I'm trying to say. National board says it's on a case-to-case basis, and you have to justify saying proof that you've been 10 years in neonatology with research papers, etc. in neonatology, and it is up to them to accept, or because they say nascent super specialties. For example, critical care, they still accept MD general medicine or MD anesthesia for critical care faculty, provided you have the experience. Fellowship programs are not accepted because it has to be MCI approved qualification. They do have a criteria saying non-MCI approved, but it is just additional qualification, but that is not a criteria. So you can apply, but it is up to national board to decide whether they are going to accept it.
Okay. Dr. Charu, hope that answered your question.
Thank you, sir. Yes, sir.
Yeah. So any more questions? I think we should wind up the session. Thank you, Dr. Prashant and NNF team, for giving this opportunity to moderate the eminence. And it's been wonderful to hear all of you. Over to you, Dr. Prashant.
So thank you, our speakers. I request Kishore sir, would you like to give any final comment?
Kishore, Dr. Kishore sir. I think so. He should not come to the line.
Him. Yes, sir. I can see his name. Anyway, no problem.
No. He should not come and talk because of election code. So from today onwards, he won't come. Even his talk is being given to Dinesh Chirla. So he should not come. He should not give any comment or any talk till the elections, Prashant.
Okay, sir. Okay. No problem. Anyway,
tell thanks to everybody. Everybody has given the knowledge to us senior people, please.
Yeah. So on behalf of NNF Karnataka, we would like to thank Swarna Rekha Bhat ma'am, Dr. Suresh, and our panelist, esteemed panelist, Asha ma'am, Dr. P.V. Ramarao, and Maya sir. Thank you once again, and thank you, Dr. Shiv Shankar, for moderating so well. So this journey of understanding the health infrastructure, and today we had a wonderful session of how important the academics is, and it's a heart of every institution to make it the best place for the practice and best place for the patient with upgradation of knowledge. So today's session has clearly given us things very clear that knowledge is powerful, and we need to respect the knowledge, and we have to make sure that we have to share the knowledge with adequate training and with adequate blend of the mix of knowledge from the senior to junior, and it should be a two-way communication, and all the institutions should be eager enough to start an initiation or to make a start for academics. Thank you one and all. On behalf of NNF Karnataka, our president, vice president, and entire team of NNF Karnataka, once again, thank you. We will catch up again this coming Wednesday. We have a wonderful session coming up about the brand building, marketing, and ad, which is very important at this point of time in a social media era. So Dr. Dinesh Chirla and we have other wonderful speakers who will be talking on this. Thank you one and all. Have a great evening, great Sunday evening. Thank you.
Thank you.